So I'm going to introduce our last scientific speaker, and then we will come to the lawyers. Martin Kulldorff, Professor Kulldorff, thank you for being with us. You're from the Department of Medicine, Harvard Medical School, and you have done, and you're going to explain to us a great declaration, the great Barrington Declaration. Are you there? Voi switcher?
Yes, I'm here. Thank you so much.
Thank you. We just don't see you yet, but it's coming.
I have some slides I could use. Should I share my screen, or I sent it also to Ingrid?
I think we can see you. Did you take a document you wanted to share?
Yes. Should I share my screen, or I can talk without it also?
Yes, you can. Can you do it? She allowed you.
No, I'm disabled for that.
Okay, just a minute.
I can talk without the slides. That's fine.
We can hear you, so that's good.
Okay.
And c'est bon?
So
okay, it's good.
Thank you so much for having me. It's a great pleasure, and thank you for all the great work that you are doing to bring a little bit of sanity to this madness that we're experiencing.
Thank you.
I wanted to talk a little bit both about the Great Barrington Declaration, but also some of the underlying principles of public health that we have thrown out the window during this pandemic. And for those who are interested, I sent out a tweet about these things earlier today, listing 12 forgotten principles of public health. So one is that in public health, it's important that we do not only look at one disease like COVID-19, we have to look at all aspects of public health. And we have to look at what collateral damage or other consequences or harms are caused by whatever measures we take. And that has completely been forgotten during this pandemic. And we have seen now that, as both the previous speakers was mentioned, that we have enormous collateral damage from the lockdowns and that strategy. We have plummeting childhood immunization rates. The cardiovascular disease outcomes are much worse. We have fewer cancer cases, but that's not because there's less cancer, it's just because we're not detecting them, and then people are not getting the treatment that they should have. And that might not result in more deaths this year so much, but it will in the years to come. So something we have to live with and die with for the next couple of decades. We also have, of course, the mental health deteriorations, both among old and young people. And so that's a very tragic aspect of our response to this pandemic. And as time goes, we're going to get more and more data and more numbers exactly of how big this problem is. And the second principle of public health that we have forgotten about is public health is about the long term and not about the short term. And a lot of the media and a lot of the scientific discussion about this pandemic is about how many COVID cases there are this week and how many deaths there are this week and so on. And what happened in the spring, the lockdowns that I'm sure had some effect on suppressing the COVID-19, but it just pushes things in the future so that we know how to deal with it in the fall instead. So from a public health perspective, that doesn't make any benefit. It just pushes the problems into the future. The third principle that we have forgotten about is that public health is the public health for everybody and not just for one group. And what we've essentially done with the lockdown, we have protected young adults who can work from home, who are at very, very low risk, like lawyers, like journalists and scientists, who don't need protection because they have minuscule risks from COVID-19. Instead, but at the same time, there are older people in the workforce in their 60s and some in the 70s who are working as a cab driver, as a janitor at the supermarket or at the meat or food processing plants who are exposed even though they are high risk. So we have shifted, the lockdown has shifted the burden of this disease from the affluent to the less affluent. And I'm going to see if I can share the the screen again. Let's see. Can you see this on the screen? So this is an example from Toronto in Canada from the spring. You can see in the beginning of March, there was an increase, there were COVID-19 cases increased about the same in affluent neighborhoods, which are the two lower graphs, and in less affluent neighborhoods, which are the two upper graphs. One is by income, and the other one is by number of minority people. And then we had the lockdown in March 23rd. And you can see that after that, it continued to increase in the less affluent neighborhoods, while it started to decline in the more affluent neighborhoods. So in Toronto, as well as in many other cities and places around the world, we were quite successful in shifting the burden of this disease from the less affluent, from the more affluent to the less affluent. So it's the less affluent who has taken the brunt of the burden of this disease, who has built up the herd immunity that eventually protects all of us. And we can see this also from mortality in Toronto, that the mortality has been much higher among the less affluent versus the more affluent people. Let me see now. Now you could see it didn't go down to zero, because we can never anywhere, because in a pandemic for infectious disease, we can never get it down to 0 cases. So people who try to suppress it completely, or who want zero COVID, once we have the disease in the country, that's impossible, and that's just something that creates more problems and actually higher mortality by even trying that. So that's another principle, that while we cannot completely eliminate risk and harm, but we have to try to reduce it as much as possible. Another principle is that when we have any disease, what we have to focus in is protecting those that are at high risk. And in terms of COVID-19, while anybody can get infected, the risk of mortality is more than 1,000-fold difference between the oldest and the youngest. So the oldest are at much higher risk. So for old people, COVID-19 is worse than the annual influenza. For children, COVID-19 is much less risky than the annual influenza. So instead of, as we have done the general lockdowns trying to protect everybody, the key is to protect all people. And there are a number of ways that one can do that using standard public health measures that we haven't used. Doing more testing and less at nursing homes, for example, doing less staff rotation, having older people live their life without having to be in a crowded setting, without having to go to the supermarket, minimizing multi-generational interaction by letting, for example, students to be at the universities instead of sending them homes with their older parents or relatives. So there are many of those very standard measures one can do to protect the older high-risk groups that has never been used. Now, when we have a vaccine, that's one more way to protect older by prioritizing older people for vaccination. But tragically, many of those standard practices were never used during this pandemic, and instead there was an attempt to suppress it from the whole population, which was bound to fail, and which certainly failed to protect older people from this virus. And we have seen that in the statistics. Another principle that we have ignored is about contact tracing. So contact tracing in isolation of contacts it's an important tool for many infectious diseases. For example, sexual transmitted diseases, as well as Ebola when that came to, for example, the US. But it's a useless and counterproductive technique for a common infectious disease like influenza or COVID-19, and by default for any pandemic. So, and we can see how that has failed. There has been enormous attempts to it, but they have failed. And it's actually counterproductive because people don't want to talk to these contact tracers. And then 5 or 10 years from now, maybe we have another disease that where we do have to use contact tracing, but then people are going to be very skeptical and hesitant about it. And it will be much more difficult to use it when it's actually maybe important. Another one with Mike Gidon talked about is this with cases. A case is only a case if somebody is sick. And to call asymptomatic individual cases is something very novel in public health that we have not used before and we should never use again. And so while testing is important in a hospital setting to know if what somebody is sick from, as well as in, for example, nursing home to protect all the people, to do mass testing of asymptomatic people is counterproductive and damaging. For example, you test schools and then the schools get closed and then the students do not get any, their teaching, and education is important for students. Both for their education, but also for their physical and mental health, as well as for social interaction to learn that. And we can see, I mean, if you look at it scientifically, Sweden was the only major Western country who didn't close schools, or kept schools open throughout the spring and during the pandemic for ages 0 to 15, childcare and schools. And of the 1.8 million Swedish children, exactly 0 had died from COVID-19 during this time. And that was done without any testing, without any mask, and without any social distancing. Sick children was asked to stay at home, and that was it. And also teachers were at no higher risk than other professions. So we knew from that it's safe to keep the schools open. There's no public health reasons to close them, but despite that, there are in the United States many schools that are still closed. And then another aspect of public health that's really troubling long-term also is the trust in public health. There are no trust. The trust in public health has deteriorated greatly for good reasons. But it's a two-way street there for public health officials and public health scientists to gain the trust of the public. Also, they have to trust the public. In any public health, it's very important that you trust the public. And that trust hasn't been there. So that trust has to be in both directions. And problems is like when you use shaming or fear or exaggerated fear, when you try to build up fear that's unwarranted to get people to do things, that is enormously damaging to public health, both short-term, but even more long-term. And that's going to have consequences for the future. The way, for example, that the lockdown has been handled by public health may now reduce the confidence in vaccines and so on. So those are enormously sad consequences that we're going to live with for years to come, and we have to find some way to reestablish trust in both directions between the public and public health officials and public health scientists. Another thing that has been thrown out the window is that in health, in medicine and public health, there are many things we don't know. And we have to be very honest about what we do not know. And that hasn't been done. There are people have been putting out like the Imperial College prediction models where you guess something for the input parameter, and then you calculate what comes out, 2.2 million deaths in the US and 500,000 in the UK, for example. But those numbers are very dependent on that input parameter that was simply guessed, so then the output is also a guess. So to treat this as some kind of a fact or reliable, that's very unfortunate. Another example is this new strain now with COVID-19. We don't know how it differs from the other. So we don't know if it's things. So we have to be very honest about that. We don't know about those things, and to use that as a scare tactic for the population, like I think it was done by the Secretary of Health in the UK, Matt Hancock, is so wrong. That's not how you deal with public health. Another principle is that in public health, like also science, you have to have an open debate, an open discussion, open discourse, where different people can put out theories, whether they are right or wrong, and they are discussed. But that was thrown out the window during this pandemic. And those of us who had a different view on this back in the spring, we were basically silenced or censored or ignored. And it's only recently during the fall that it has been a more vigorous debate, which is great. But that should have been happening already in the spring. And that's also going to have enormously bad consequences for the future. And we have to find some way to deal with that. So we have sort of gotten now some kind of a herd thinking, and people are afraid of speaking up against the established narrative about this pandemic. The last one, 12th one of the principle is in public health, we have to listen to the public because they are actually the ones who are living these public health consequences. They are the ones who are seeing their child thinking about suicide. They are the ones seeing the old person, their mother or father or grandparent in the nursing home, and they can't visit them, who is sort of just slowly losing interest in life. These are the ones who can't feed their children because the market is closed, or and especially in the third world, but also in Western Europe. So that's another problem, that public health officials have sort of tried to impose their message, but not listening to what people are saying. And that's an enormously important part of public health, to listen to the public. So those are, in my view, sort of is stunning. As a public health scientist, I worked on infectious disease outbreaks for a couple of decades, working with most interacting with most state and many national health departments in the world about different infectious disease outbreaks and disease surveillance. And it's stunning to see how the principle of public health has been thrown out the window. So what we did in October, because there were several of us who are infectious disease technologists who were very frustrated about the situation, we tried to say something. Often we couldn't make our voices heard, and when we could, we were sort of dismissed as just one lone person, an outlier. So together with Professor Gupta at Oxford University, who in my view is the preeminent infectious disease epidemiologist in the world, and Professor Dr. Jay Bhattacharya at Stanford University, who is an expert on infectious diseases and its effect on the vulnerable population, we came together and wrote a one-page declaration called the Great Barrington Declaration. This was in early October, where we and there's nothing new in this declaration, because it's basic public health principles, and the three of us, as well as many others, have been trying to promote ever since the beginning of this pandemic. But it's that we should use a focused protection strategy where we do a better job protecting older, high-risk people using standard public health practice, at the same time as children should go to school and young adults should be allowed to live their lives normally. It's always good to wash your hands frequently, and yes, if you're sick, stay at home. That's good advice not only for COVID-19 but for influenza and other infectious diseases. But for this group, the damage from the consequence of the collateral damage are much worse than any minuscule risk from COVID-19. So we put out this Great Barrington Declaration, and you can read it on gbdeclaration.org. And there's also an FAQ that describes things in more details. And by now we have over 750,000 co-signers, including over 10,000 medical and public health scientists, as well as many medical practitioners. So this is clearly not a fringe opinion. It's not out there in the media as much, but there are many within the medical community who agree with this declaration. And as I said, this is nothing that we invented. It's something that many people have been arguing for a long time. So that's sort of my little talk from COVID-19 from a public health perspective. So thank you very much for listening, and I appreciate that.
Well, thank you. That's a very good contribution. Thank you. That was what we needed, you know, public health expert and analysis of the public health paradigm in COVID. I just have a student from the University of Fribourg in Switzerland who is here, and he would like to ask you a small clarification, right? Yeah, you can come here.
Yes, thank you.
So Leonard,
Yeah.
Leonard Winkler.
Hello, yeah, my name is Leonard Winkler, and yeah, Professor Kulldorff, thank you very, very much. I highly appreciate your input and the declaration. I read it some days after it came out, and I spread it. And I'm quite consistent with it, but there's one point that troubled me at the time and also today, or I not totally understand it, and that is the point of that you say mass testing as a prevention is good for old people. And before today, you pointed out that there is a problem of testing asymptomatic people because that leads to false positive. And so if we do mass testing under the condition, as it is to my knowledge in my country, Germany, and also Switzerland, there is testings in labs on a broad range with 45 cycles, a CT value of 45. So when a positive test is there, they go down sometimes to 35, which is still way too high from my knowledge. So if you say on the one hand, mass testing, and on the other hand, there's a problem of asymptomatic people, even if we test old people on a large scale, asymptomatic with 45 cycles, we have a lot of positive tests. So I don't really get the consistency in that point of your strategy, and I would like to hear your explanation to that, if that's possible. Thank you.
Thank you, Leonard, and that is a good question. So I'm very much against mass testing of asymptomatic people. For example, we should not do testing of school children or university students and so on. There's no public health purpose of that, and it's actually detrimental because people will simply close the schools or tell people to stay home from schools when they can't go to schools. I also don't think it's necessary to test people who are mildly symptomatic. They can just stay at home until they feel well. There's no need to test them for that. Where testing is important, I think, is, of course, if somebody is seriously ill, it's important in order to treat them to know if they have COVID-19 or if it's something else. So their testing is important. The other one is to protect very vulnerable people, like in nursing homes. So I think it's important to test nursing home staff, not for the protection of the staff, but to pick up if there are, so that they don't go to work and spread, if they're infected, that they don't spread it to the residents of the nursing homes. And I think that should be fairly frequent. And I think it's okay also if they are, you can do it whether they are asymptomatic or systematic. Because the purpose there is not to protect them, but to protect the people they work with. And when it comes to the threshold, I think in such a situation, it can be, it's more important to be more safe than sorry. So maybe somebody was tested positive, but they weren't really positive. Well, they get to spend time at home, and that's unfortunate because you need them in the nursing home. On the other hand, it's better to be safe than sorry, so they don't infect any of the residents who are very frail and at high risk. So what threshold you use for the test will then depend on what the situation is.
Okay, thank you very much.
Thank you. Thank you very much. Now, so if you agree, we're going to go. We're going to have all the discussion with the lawyers here, and let me introduce first Maître Carlo Brusa, who is from France, and he will introduce himself also. Then Dominique Desjarlais, who is a lawyer in Quebec, and who's using European scientists to do the case in Quebec. And then we have online on the Zoom Rocco Galati, who's a constitutional lawyer, president and director of the Constitutional Rights Center in Canada. But I will let you, introduce yourself.
I prefer that you introduce the Quebec lawyer.
Yeah, I will let
because my idea is to try to find a global solution for the peace.
Yes, okay. So shall we, first I would like to ask you, Professor Kulldorff, do you work with the lawyers?
I do not work with lawyers. My colleague and co-author of the Great Barrington Declaration, Dr. J. Bhattacharya, he's done a lot of that work, but I have not done any of the legal work.
So the declaration is working in some way to make this declaration something more legal or ethical or a guideline for the future? Just want to know.
Yeah, it's nothing legal. It's more hopefully a guideline.
Mm-hmm.
And we also see it a little bit as a shield and a spear for other people who there are many people outside of the public health fields who actually understand public health quite well and who are arguing against the lockdowns. And they were often very much dismissed because, oh, you're not an epidemiologist. You don't know anything about infectious diseases. So I think by having three people who we have all worked with infectious disease technology for decades, to have us state sort of clearly in one page, state sort of the principles, I think that is a help for other people to argue the case against these very damaging lockdowns, both in private and in public and in the media, as well as lawyers in the courtrooms.
Okay, thank you very much.